Today I'm going to speak about the question number 13, in which I'm going to resolve the dilemmas that is present in the use of different types of anticoagulants. So in therapeutic wise as well as when it comes to pharmacology, I think that you have come across many therapeutic pharmacological agents that are available which can be utilized as anticoagulants, and also this might involve both oral as well as intravenous drugs. Now, if you know about the current market as well as if you have already done your cardiology appointment, you might have come across many novel agents. For an example, as anticoagulants, earlier we knew only about warfarin, but now there are new drugs which are termed as direct oral anticoagulants, or also known as novel oral anticoagulants. So in simple terms, DOACs. So there are multiple DOACs that are available. It ranges from apixaban to edoxaban to rivaroxaban, and you should know what to use, when to use, and what dosages to be used. In addition to that, there are also multiple intravenous thrombolytic agents that you have come across. It includes enoxaparin, lower molecular weight heparin, which is, and also unfractionated heparin, and the novel ones which are also utilized nowadays, which are Fondaparinux, bivalverin, and argatroban. So practically speaking, you might have come across these names when you were studying pharmacology, but you might not know when to use any of them, because each of these are now in the curriculum and being used in the therapeutic process. So today I'll be focusing on this, and I have already posted around four questions which have summarized all of these contents. Right. So we'll start with acute coronary syndrome. In acute coronary syndrome, most of the time, if the patient is having a STEMI, a preferable modality of intervention would be a PCI. So you undergo PCI. Now, in the unit itself, when a patient is opted to go for a PCI, you might have seen that he's given aspirin 300, clopid 600 with an atorvastatin of 80. The sole purpose is to make sure that the blood is kept in a flowing manner and there will be no thrombosis formations or else clot formation. But clopid being a P2Y12 inhibitor, it is not the best of pharmacological agents that is available. Nowadays, there are two better drugs that can be used. So, you might have come across these two terms, prasugrel and ticagrelor. The best therapeutic index is actually shown by prasugrel. However, the bleeding, whatever has a better therapeuticity will have a higher risk of getting a bleeding as well. So prasugrel will inadvertently has a higher bleeding risk. So in cases when there is previous TIA, transient ischemic attacks, strokes, or other susceptibility to bleeding, better not to you go for these two drugs because they have very high therapeutic potency. So prasugrel, and when somebody wants to think about either of the drugs, now let's assume that the bleeding is somewhat mitigated and you want to go to either of these drugs, then you think about whether the patient has had previous TIAs or strokes. If TIA and strokes are there, then prasugrel is an absolute contraindication. Then better to go for something like ticagrelor. Another IV P2Y12 inhibitor that is available is cangrelor. Not not the usual drug that you might see in Sri Lanka, but this again is a drug. Since each of these drugs cannot be given, it's an oral drug as well, cannot be given during a PCI, but cangrelor can be. So in during a PCI, if you are thinking about the requirement to prevent clot formation, and you are thinking about a drug that has to be given to prevent clot formation, think about cangrelor. So during PCI or surgery. So this is what you need to know in acute coronary syndrome. Now the dilemma in anticoagulant use. So what are the anticoagulants that are available? Anticoagulants. So there are two types. Either you go for direct oral anticoagulants, or else you go for warfarin. Now there are circumstances where warfarin is a must. You should go for warfarin. For an example, if the patient is already having a kidney disease with a EGFR of less than that of 15, and EGFR less than that of 25, so stage 4 and 5, in such circumstances it is advisable to go for warfarin because it has the least impact on the kidneys. And also let's assume that there is, now whenever, what are the circumstances where you have to go for anticoagulants? When you are thinking about higher thrombosis risk. For an example, if the patient has had a previous DVT, unprovoked DVT, or a provoked DVT, you have to give an anticoagulant for around 6 months of period. A provoked DVT, when you have to give anticoagulants for the lifelong. And there is the requirement of some anticoagulants in circumstances where there is this thrombosis risk. For an example, Leiden 5 disease, and in for an example, any vasculitis or antiphospholipid syndrome. So these are circumstances where you go for anticoagulants. Then you have to choose whether you have to go for a DOAC or a warfarin. So warfarin is preferred if the patient is having a CKD of an EGFR less than that of 25, and if the patient is already having antiphospholipid syndrome with all three antibodies positive, which is lupus antibody, cardiolipin, as well as anti-beta 2 glycoprotein. So if all three are positive, better to go for a warfarin which has a better potency than that of a DOAC. And also, whenever there are valvular involvement, if there is valvular disease, for an example, let's assume there is mitral stenosis, there is aortic stenosis. In mitral stenosis, there is this turbulence of flow which will lead to the formation of clots. So better to go for a drug which will prevent the clot formation, which is sometimes not applicable by giving DOACs. DOACs is not enough, not sufficient. So go for warfarin. So whenever you are thinking about any atrial fibrillations, any arrhythmias, any DVTs, any as an prophylaxis for DVT recurrence, so in such cases you think about anticoagulants. But in anticoagulants, whenever if the patient is having antiphospholipid syndrome with all three antibodies positive, CKD with stage 4 and below, and also in valvular disease, it's recommendable to go for a warfarin. Now, what is the range? Usual therapeutic range is 2 to 3 PTNR. PTNR has to be done annually, monthly, and you have to change the warfarin dose. Usually it comes with 5 milligrams, so 5, 6, and sometimes you can go up to around 10 as well. So in you have to change these drug doses to make sure that the therapeutic index is met. So you have to maintain a PTNR of 2 to 3. But this is not applicable if the patient is having mitral stenosis. If there is mitral stenosis, because of the higher turbulence, better to go for a PTNR range of 2.5 to 3.5. And also in circumstances when there was let's assume that there was this patient who has had a PTNR of 2 to 3 and had another thrombotic event. So in this case, inadvertently, the PTNR increases from 0.5. So then the range comes from initially from a 2 to 3 to a 2.5 to 3.5 range. Whenever the patient has underwent any mitral valve replacement, again the PTNR range goes to 2.5 to 3.5. But not in aortic valve replacement. So it is only in the mitral because the highest turbulence is seen in mitral. Right. Now, what else? Then, what are the DOACs that are available? Now, if I go to the availability of DOACs, there are 4 specially that need to be known. So, there is apixaban, there is edoxaban, there is rivaroxaban, and dabigatran. Out of these 4 drugs, all these 3 drugs are direct factor 10 inhibitors. But dabigatran is a direct thrombin inhibitor, which means it has the highest potency. Thrombin inhibitor. So again, at least the EGFR should be more than that of 25 to think about DOACs. And even in these 4, apixaban is the one which has the least influence upon the kidney function. So it is around 25%. But when it comes to edoxaban, it is around 50%, and rivaroxaban it is around 33%, and but dabigatran is around 80%. So maximum is either dabigatran. But dabigatran is somewhat preferred in patients who have liver disease. So because the majority of the drug would be broken down and mechanistically utilized in the kidney rather than that of the liver. So dabigatran has that condition. Right. So when you are thinking about these 3, it has been, I would preferably change here it should be rivaroxaban, and here it could be edoxaban, right? So this is 50% and this is 33%. Right. So thinking about apixaban and rivaroxaban, the best would be through trials it is identified as apixaban. But when to, because now both of these has GI bleeding risk. But it has been identified through trials that apixaban has lesser bleeding risk when compared to rivaroxaban. So better to go for apixaban. But in circumstances where there is cancer-related DVT, cancer and DVT, better to go for something like edoxaban. So it has been again another trial, Hakusai, that was done, shows better to go for edoxaban. So these are the 4, simply speaking, so these are the 4 drugs that are available, and these are the circumstances where you have to use each of them. Now we think about the thrombolytic agents. The usual thrombolytic agent that we use is enoxaparin, low molecular weight heparin. But these are used in circumstances where there is active DVT, then there is prophylactic DVT, after management of STEMI, and even in the initial stage of non-STEMI. Initially, we give 6 doses of enoxaparin in the non-STEMI management, and then we continue with dual antiplatelet therapy. So that is the usual utilization of these drugs. But there are circumstances when you have to go for unfractionated heparin. For an example, now what is the difference between these two? Enoxaparin and unfractionated? Unfractionated heparin has a quicker onset of action, and it can be reversed easily as well with the antidote, which is protamine sulfate. So in cases when there is surgery that should be done, which need to be reversed at a very quick time period, in such circumstances, it would be better to think about, or recommendable even, to go for unfractionated heparin, even though it has very high risk of bleeding. In cardiac surgeries, for an example, these days, since with the dengue epidemic, when there is low platelet, when the patient has an concomitant MI, you think about giving unfractionated heparin rather than enoxaparin, because it can be reversed easily if there's any sort of a bleeding that happens. But the risk of bleeding is very high as well. So both of these drugs are utilized in the requirement of a thrombolytic agent. But unfractionated heparin has a very high risk to activate antibodies against platelets that will cause platelet aggregation and thrombi formation. It is called heparin-induced thrombocytopenia. This is somewhat higher in unfractionated heparin than that of enoxaparin, but both has this potentiality. So if any by means, if a patient gets a heparin-induced thrombocytopenia leading to thrombosis, then both of these drugs has to be stopped. Then it would be better to go for the other drugs that can be used as an alternative. For an example, Fondaparinux. I think if all of you, if you have read Kumar and Clark, most of the time they recommend Fondaparinux as the management in non-STEMI. Whereas in Sri Lanka, we usually give enoxaparin, because Fondaparinux has the least bleeding risk. And it is even found better to be given in trials. There's a little bit of superiority as well when it comes to high risk category of non-STEMI management. So these are direct factor 10 inhibitors, Fondaparinux. What else? The other two drugs that can be given, so this is usually given as a off-book medication because of the availability. But the best two drugs in circumstances of heparin-induced thrombocytopenia would be bivalirudin and agatroban. So both of these, again, bivalirudin and agatroban are both direct thrombin inhibitors. So these are utilized in patients who have had heparin-induced thrombocytopenia. So what to be given? Usually it is preferable to use bivalirudin when a patient has underwent PCI and during the PCI has had a heparin-induced thrombocytopenic event. So bivalirudin is preferable. Otherwise, for other medical hits, usually agatroban is advisable. Unfractionated heparin, again, if there's any circumstances where there is these cardiopulmonary surgeries, bypass surgeries, so unfractionated heparin is the one that is used, as I said previously as well, because of its easy reversibility and higher potency. So now I think I have completed the therapeutic management and the circumstances, and I have illustrated the circumstances of the use of each of these drugs. So need to keep these points. These are again very subtle MCQ points that might come across your way. If there is any sort of a difficult and an advanced question that is to be asked, this is what it will be expected from you. So there are much advanced stuff that need to be known as well, but at an undergraduate level, this is more than sufficient to go to get a better mark when it comes to the MCQs. So right, we'll meet with the question number 14. Thank you.